I invite Dr. Harjit Dumra. He is a consultant transplant pulmonologist, a sleep medicine and critical care specialist. Sir has a keen interest in pulmonary hypertension and interstitial lung disease in chest. He is an expert in lung transplant as well as interventional pulmonology also. Over to you, sir.
So to begin with, I was just thinking of complimenting all the physicians present here. I work in a single specialty, pulmonary and critical care, and for all of you to be here listening to so many different specialities and being able to relate to them, hats off to you, because your job is much more difficult than mine is, where I have to focus on a single specialty. Moving forward, changing track from platelets to lipids to interstitial lung disease, from focused diseases to broad disorders. And believe me, teaching ILD on a Saturday afternoon post-lunch is one of the worst times to be doing this. I'll try to make it relevant and interesting. So these are the common linked lung disorders in 2025. And as you can see, the list is not something which you would expect. And ILD is not one of them. So clearly, ILD is not a common lung disease. So you won't see it very commonly in your general patient population, and that is why it has to be looked for, searched for. There were 10 commandments in the Bible. I'm going to give you 12. Why? Because ILD management is more complex than reading the Bible. And I'll try to stick to 12 and make them relevant when you go back from here. At least you'll have something as to how do you manage ILD. So giving you this case, 59-year-old male, farmer, who basically has been a smoker. He's had shortness of breath for the last 8 months, intermittent cough, vague joint pains, comorbidities of hypertension, diabetes, thyroid disorder, and GERD. He's had arthritis around 15 years back, for which he's never been on medication, which was allopathic. There's no significant past history there. He has a family history where his father died of lung disease at a very old age. He's been exposed to some insecticide sprays as he's a farmer. He's not had any pets. He tends to feed birds, but this was almost a few years back. Primarily among them were pigeons. When I see this patient, he has basically primarily involvement of the musculoskeletal system and the respiratory system. He has bilateral basilar rals, and you can see that there are joint involvements as well. This is what he comes to me with. This is his chest X-ray. As you can see, nothing much there, some reticulation. The ECG is fine, and the PFT shows some restriction. Now, when this kind of a patient walks to your clinic, you suspect an ILD. There's no way to confirm it at this point of time. And you want to start investigating him. And these are some of the thoughts which cross your mind. What's the first step? You have a suspicion. Would you start treatment? Would you be wanting to investigate him? Would you send serology? Or the best part, would you refer him to an ILD center? How many of you would refer to an ILD center or a specialist right away when you suspect an ILD? Just a show of hands. Okay, so a bulk of you would still want to investigate and treat him. So this is a lecture which is relevant to your practice because frankly, this is what you're supposed to do. Now, when you encounter a patient with chronic dyspnea, ILD is not common among the list of causes causing dyspnea. You have cardiac causes, you have neuromuscular causes, you even have physical deconditioning and obesity contributing to dyspnea. And even if you suspect pulmonary, there is a list of diseases which you need to suspect before you sort of come down to on a focused ILD presentation. Not only that, ILD is associated with comorbidities which can cause dyspnea. So you can have ILD with embolism, you can have ILD with pulmonary hypertension, you can have ILD with COPD and lung cancers, and all of that could be just part and parcel of the ILD. So the first rule is try and look at associated causes of dyspnea and try to rule out alternative causes of dyspnea. First, because in a large group of ILD patients, treatment is not easy, some of them are irreversible, but a large part of the other etiologies can be treated, and at least you can give symptomatic relief to this patient. What is the second and the most important point? First and foremost, when would you suspect ILD? This patient group has a peculiar presentation. They are breathless only on exercise, so it's not like asthma that you can have breathlessness at rest. It's only exertional. On physical examination, if you can pick up clubbing and bibasilar rals, that is a very important sign to suspect ILD. And on the chest X-ray, look at the basis. And if there is volume loss in the lung, there is basal reticulation, this is one person who possibly can have ILD. Are there any patient pools where you start suspecting it more frequently? Maybe in the elderly population, but connective tissue disease can come up in the middle age. Patients who have been exposed to certain occupations, minors and so on and so forth. Patients who have had a family history of ILD. Patients who are on chemotherapeutic drugs, and this is now going to be a big chunk because we have a lot of ILDs coming with drugs which are commonly being used for cancers, and obviously smoking is the be-all and end-all of all respiratory disorders, so any smoker can get ILD. So this is the mnemonic you need to remember when to suspect ILDs. First and foremost, you rule out these things because these are easily to treat, these are reversible. So some infections like miliary TB or pneumocystis can present as an ILD. Some malignancies can present as an ILD, a lot of drugs can present as an ILD, and there is a lot of them which are commonly used. Nitrofurantoin when given chronically for UTI prophylaxis, amiodarone which is used long-term for arrhythmias, anticonvulsants which are commonly used for seizures, a lot of these can cause ILDs, and these are easy to identify, easy to rectify, and hence the treatment of these groups of patients is important. And last but not the least, smoking peculiarly causes some ILDs where just cessation of smoking will improve the ILD. So think of ILDS when you start thinking of ILDs. The third thing, ILD is a broad term. It does not indicate a specific type. So whenever you encounter a patient of ILD, you need to be looking for a specific type. Why specificity is important? Because the prognosis of each ILD might vary, treatment will be different, and some of them can be beautifully reversible. Now this is the complex chart of the list of ILDs which you commonly encounter in practice, and I'm not going to bore you into this, but this is relevant for management. So whenever you have an interstitial lung disease, a lot of them have idiopathic or unknown causes. The most important out of this is what we call IPF or idiopathic pulmonary fibrosis. This single ILD is responsible for 90% of mortality in patients with ILD. So this has to be picked up upfront. You cannot miss this ILD because this is one ILD which destroys the life of the patient in a very short span of time. Why is it relevant? Because this particular ILD starts with fibrosis, it is irreversible and it is progressive. A lot of other ILDs are inflammatory and they have known causes. The commonest ones are ones with connective tissue disease, sarcoids, and HP. And I'll come back to that a little later. But these are the four ones which you need to remember. IPF, CTD, HP, and sarcoid, which you will commonly encounter in practice. A lot of the known ILDs are treatable. Some of them are reversible. A lot of them can be made static with due course of therapy. If you look at the ILDs prevalent in our country, again, these four dominate the group, and that is why rather than look at the bulk of ILDs, focus on these four. As physicians, that should get your job going. So think of common ILDs first. Don't think of, there are 200 causes of ILDs, think of 4. That is where you can be an expert at. So how do you go about diagnosing this disease? The HRCT is the single most important investigation to diagnose ILD. CT chest will give you a conclusive diagnosis and it will also tell you the specific type of ILD. In very few patients, you will have to resort to biopsies or other investigations. Remember, an X-ray misses an ILD in 40% of patients, and a CT chest is the benchmark and the investigation of choice when you suspect an ILD. What do you commonly see on a CT scan? There are different patterns, different kind of presentations, and I know all of you are not expert radiologists who read CT, but these are some of the patterns which we commonly see. Crown glass, nodules, reticulations, mosaic, consolidations, and cyst. Why are these patterns important? Because these patterns represent inflammation. Remember, ILD has two components, inflammation and fibrosis. Inflammation is designated by these patterns, and these patterns respond to steroids. Compared to that, this is called honeycombing, where there are layers of cysts in an ILD, and this pattern does not respond to steroid, and antifibrotic becomes the drug of choice. And that is why looking at the CT, at least you can make an impression whether you are dealing with an inflammatory ILD or a fibrotic ILD. Based on the pattern, your radiologist will give you a diagnosis. And remember, it is extremely relevant that you don't subject patients to needless scans at places which are not going to give you the right interpretation. So a single scan can cause exposure to radiation, but it doesn't add to the diagnosis. And hence, interpretation of HRCT is best done by radiologists with an interest in thoracic imaging and which have access to clinical inputs. This is extremely relevant. Why? Because a lot of patients come to us with a CT scan just done 3 days before they come to the clinic, and we have to repeat the scan, which is expensive for them and also exposes them to needless radiation. So when sending for a scan, if you suspect an ILD, send it to a center where there is experience in interpreting interstitial lung disease and the radiologist is knowledgeable. So these are the 4 patterns which I was telling you about, the 4 different ILDs, and all of them look very different on the CT. So a good radiologist will be able to tell you what this patient is suffering from. Not only that, as physicians, you also get a lot of information from the CT which others might not be looking at. So you can even ask your radiologist to look for this because this will have a bearing on your treatment. So you can have pulmonary hypertension, which is a bad prognostic factor. This patient could be a smoker and he could have an additional emphysema. Sometimes you might pick up an associated lung cancer. We were just talking about lipids, and you can have coronary calcification, which will tell you about an associated comorbidity of coronary artery disease. You can have scleroderma with an hiatus hernia, which will give you a diagnosis of the etiology of the ILD, and sometimes you can even pick up heart failure. So a single scan, in addition to the ILD, will tell you a lot of other stuff. This patient had this kind of a scan. Again, we are not going to go into the details, and my radiologist gave me a differential, and it was a wide differential. So again, there is no way of me knowing what this ILD was. So what is the next course of action once you have gotten the CT scan done and you still don't know too much about what is the kind of ILD this patient is having? The next step is to biopsy this patient. Now with time, biopsy methods have evolved, and we resort to 3 different kinds of biopsy. The forceps biopsy done with a bronchoscope, the cryo biopsy done with a bronchoscope, and the video-assisted thoracic surgery. And again, these are complicating terms, but what is relevant to your practice is you get very small pieces with a bronchoscopic forceps biopsy, you get bigger pieces with a cryo biopsy, and you get massive pieces with a VATS biopsy. The risk of complications goes up as the chunk of tissue you are removing from the lung increases in size. So the VATS biopsy is more complicating, more chances of bleeding, more chances of infection, more chances of an exacerbation being flared up, while the forceps biopsy has the least. But today, the gold standard has become a cryo biopsy, which gives you reasonable size of tissue and also causes less complications. What else do? You also can resort to serology. Remember, this patient had some joint pains, he was exposed to pigeons, and these are some of the serological markers which you can ask for when you suspect a particular type of ILD. So CTD markers, ACE levels, calcium for sarcoid, HP panels for hypersensitivity, and some miscellaneous markers as well. All that put together will give you some inkling of what the ILD is. Remember, all CTDs do not necessarily cause ILDs. Think of 3 when you think of ILD. The commonest ones are systemic sclerosis, myositis, and mixed connective tissue disorders. These 3 are the commonest connective tissue diseases which cause ILD. Now, based on this gamut of data which you have accumulated till now, eventually you will be able to reach a diagnosis of which is the specific kind of ILD. And this is a combination of clinical, radiological, pathological data which is assessed at what we call multidisciplinary discussion. So the clinician, radiologist, pathologist get together and give you a diagnosis. So we, in this patient, sent serological markers, and the ANA profile was positive. There was mild pulmonary hypertension on the echo, and MDD was held because we still didn't know about the specific diagnosis, and it was decided to proceed for a cryobiopsy. So the MDD now is an integral component to diagnosing the specific type of ILD, And it is often needed not only to decide about the biopsy, it also is needed as to which is the kind of biopsy, what is the treatment option, and what is the prognosis. Eventually, this biopsy showed overlapping features of hypersensitivity pneumonitis, which is an ILD which is commonly seen when your lung is exposed to external antigens. The pigeons are the commonest, and it had overlapping features with connective tissue disease. It was labeled as hypersensitivity pneumonitis with autoimmune features. Again, don't look at that name. But what is relevant is the time to reach diagnosis in this patient was 1.5 years. Now, this is the patient journey, and this happens in Rajkot, this happens in Ahmedabad, and this happens in London as well. The time spent from the initial symptoms to the diagnosis is at least 1 year. You start treatment. Some of these ILDs will progress. To identify progression, you will again lose a year or so, and that leads to death of the patient, clearly showing that as far as ILD goes, in the general physician population, the diagnosis is significantly delayed. And the most important part is it is delayed in this particular group of ILD, which is called IPF, where it is extremely relevant because the mean survival of a patient of IPF is hardly 2 to 5 years. It is less than lung cancer. And that is why for at least IPF, you need to confirm the diagnosis at the earliest. I showed you that honeycombing. That honeycombing is classical for IPF. And there is clear-cut data which says that the longer the delay to diagnosis, shorter is the lifespan of the patient. It is not only true for IPF, but it is also true for other ILDs. So at least try and establish an early diagnosis. That is the 7th important point. Why? Because time lost is lung lost. So just to summarize what I have said till now, rule out alternative causes of dyspnea. Do not stop with the diagnosis of ILD. Look for a specific type. Think of the common ILDs first. A good quality CT scan with an experienced radiologist is integral to diagnosis. If that is not going to give you a diagnosis, you can resort to a biopsy with a multidisciplinary discussion and try and reach an early diagnosis. So how do you treat this patient? There are multiple options there. There are 2 groups of drugs: anti-inflammatory, which is steroids and immunosuppressants, and antifibrotics. The 2 ones which are available to us are nintedanib and pirfenidone. So what are the basic principles of treating ILD? First and foremost, most ILDs will need long-term treatment. Some will need lifelong treatment. Anti-inflammatory and antifibrotics are the 2 drugs to choose from. Like I already told you, systemic steroids and immunosuppressants are the backbone of treatment, and this is primarily for non-IPF ILDs. If you are dealing with IPF, steroids don't work. This is a progressive, irreversible ILD, and antifibrotics are the only way to go. You need to monitor these patients carefully, and some ILDs which started off as inflammatory will progress to fibrosis, and these are the patients you need to be very careful about. How will you identify these patients? There will be worsening in symptoms, there will be worsening in lung functions, and there will be worsening in CT pictures on treatment. And that is the one way to identify patients who started with inflammatory process and now have progressed to fibrosis. And all our ILDs, most of them can have progression on treatment. So to have a simplified diagram to make this a little more clear, you can have inflammation and fibrosis in an ILD. There are some ILDs which are purely fibrotic, IPF is one. There are some ILDs which have purely inflammation. You can have in the initial period of connective tissue disease, sarcoid and HP, only inflammation. But a lot of this falls in between where you can have inflammation and fibrosis. So you will need a combination of drugs, which is a combination of anti-inflammatory and antifibrotics. So there is a huge list of anti-inflammatory drugs which you commonly use. It can be mycophenolate, it can be cyclophosphamide, it could be rituximab. Depends on the ILD you are treating with. You have 2 antifibrotics, nintedanib and pirfenidone. What I want to draw the crowd's attention is a lot of you start antifibrotics like pirfenidone in a very low dose, 200 milligrams 3 times a day, nintedanib in a low dose. If you are using antifibrotics, please try and ensure that the dose is appropriate. Otherwise, these drugs don't work. There is no head-to-head comparison between which is a better antifibrotic, but nintedanib scores over pirfenidone in a lot of trials. So, in patients who have inflammatory ILD, first optimize immunosuppression, monitor progression, and only add antifibrotic if there is progression. Otherwise, you don't need the antifibrotic. So when you're dealing with an ILD, the first question is the patient suffering from IPF? If he is not having IPF, is it a fibrosing or a non-fibrosing ILD? And if it is fibrosing, is it progressive or not? That usually answers most of your questions regarding management. And this is a similar slide to what I just told. Now, why is segregating ILD into different types important? Why? Because the single slide tells you the reason. The drug of choice for each ILD is different. So if you have systemic sclerosis, the drug of choice is mycophenolate. If you have rheumatoid arthritis, it might be rituximab. If you have sarcoid, it will become methotrexate. And if you have HP, it will be mycophenolate. Clearly telling you that depending on the specific ILD you have identified, the choice of immunosuppression will vary. The first choice drug will be different, and hence we still have to identify the specific ILD. But after all this discussion, if you are still at sea as to which is the drug which I should use mycophenolate. It will be effective in most ILDs. So steroids plus mycophenolate in most inflammatory ILDs will do the job for you. Monitor these patients and judge their progression by certain scores. And what is important is, in patients with IPF, regardless of what time he presents to you, counsel him about progression and early mortality. Prognostication in an IPF is upfront. So you diagnose IPF, this patient is going to die in a short span of time. So our patient was started on steroids and MMF. He gradually responded. He improved after a period of time, but after a short span of a febrile illness, he deteriorated. He was shifted to the ICU and needed non-invasive ventilation and high FiO2. This is the issue here. Would you refer this patient for lung transplant? Now, whenever you have acute worsening in the ILD, it could be because of a list of causes: infection, heart failure, pulmonary embolism, a drug-induced, some cancers, effusion, or pneumothorax. But it could also be because of an entity which is called acute exacerbation of ILD. So the ILD itself exacerbates, leading to acute respiratory distress. Now, whenever you have an acute exacerbation, this is a harbinger of poor prognosis, because 50 to 90% of patients who exacerbate will have mortality in the short term. So if you have availability, accessibility to a transplant centers, please refer a patient with an acute exacerbation once he is stabilized in your ICU to a transplant center. If you don't have accessibility, there is a long list of drugs which you can give this patient, but unfortunately, very few of these patients survive. Most of them would succumb. So when you are dealing with an acute exacerbation in a patient with ILD, rule out other causes of worsening. If it is acute exacerbation, then try and refer them to a transplant center. If the patient is not eligible for transplant or you don't have a transplant center, supportive care is the best you can do. We in Gujarat have a transplant centers. Ours is the only active center in the state. We've done around 14 transplants right now. So you can refer your patients, you have that option. Which are the patients to refer? Any patient in an acute exacerbation not responding to therapy, or a progressively worsening ILD denoted by these criteria. So you look at the lung functions closely. The commonest way to identify these patients is once they start having oxygen requirements, that means once their saturation goes below 90, or these patients have become disabled, bedbound, or they have moderate to severe pulmonary hypertension. These are some of the clinical markers you can look at to send these patients for lung transplants. Remember, a lot of these patients will not be able to undergo a lung transplant. Transplant is very serious business, complicated, lot of expenses, and mortality post-transplant is not something which is sort of in the range I would be comfortable with. So a lot of these patients will need supportive care. Some of these things can be practiced day to day on the bedside by all of you. This includes risk factor reduction, focus on comorbidities, giving supplemental oxygen and vaccination, and never forget pulmonary rehabilitation. So to summarize, when you encounter a patient with ILD, look at the history, look at the clinical examination, confirm the diagnosis with a CT. If you still don't have a clue, look for multidisciplinary discussion with your radiologist colleague. If the diagnosis is still not confirmed, go for biopsy. Once you have a clinical specific diagnosis of ILD, segregate them into fibrosing and non-fibrosing. Inflammatory ILDs will respond to steroids and immunosuppression. Mycophenolate will work in most case scenarios, but IPF, you only give antifibrotics. Never forget ancillary treatment and treatment of complications in all groups of patients. So I thank you for a patient listening. I know it has been a long topic, very difficult to understand, and I have tried to summarize this in a very short way. Thanks a lot.
Thank you, sir.